Next talk will be by Professor Rajesh Sinha, and sir will be speaking on anterior lamellar keratoplasty. Thank you, sir. Sure, thank you.
Thank you, Dr. Bhupesh, for the opportunity. Uh, I'll be talking about anterior lamellar keratoplasty traveling the correct depth. Well, when you are thinking about the depth of anterior lamellar keratoplasty, it depends on the depth of involvement of the cornea. Say, if it's a very superficial opacity, you can just manage by PTK, just remove the epithelium and use excimer laser to ablate the stroma. So something about 75 to 100 microns you can manage. And if the corneal thickness is good, it will maintain clarity as well as maintain the topography of the cornea. And this is how it looks like pre-op and post-op, and Rees-Buckler dystrophy, pre-op, post-op, a case of a post-pterygium involving the visual axis. After removing the pterygium, there was some significant haze, so PTK was done. It improves clarity. But if the opacity goes deeper down, earlier, even in granular dystrophy, I still remember maybe 15 years back, we still used to do a PTK, and we just thought that maybe a little bit of opacity here and there we can the patient will manage. But these days we have a better option for that, because in granular dystrophy, in any case, it will involve at least 200 microns, and in such a case, you can do a sutureless superficial anterior lamellar keratoplasty. So you create a donor lenticule of same thickness as you will be dissecting in the host, and then in the host again, you use a microkeratome to remove the tissue. Whenever there's a nodule or etc., then you should remove it manually. Otherwise, there will be the shape of the bed after creation with the microkeratome cut will not be regular. So once you remove it, you can see it has cleared up. And then if there's a cataract, then you can do a cataract surgery and then put a donor lenticule and dry the edges, and then put fibrin glue at the edges and put a bandage contact lens. This is how it looks like in the case of a granular dystrophy. Preoperative, I showed you. This is the postoperative picture of the same patient. Looks quite clear, and the patient has reasonably good visual outcome. Some patients, I have noticed that there is some astigmatism, and perhaps the reason is this: that when you're putting the donor tissue, there is some configuration of the donor tissue as well, and that is the reason for some degree of astigmatism. But the visual axis is quite clear. The one problem that when you're doing a microkeratome salc, in the periphery there can be some epithelial ingrowth, or there can be glue that can enter into the peripheral part of the tissue. So if you are doing a femtosecond assisted anterior lamellar keratoplasty or FALC, then in that case it's a case of a healed keratitis, wherein you can see it's vascularized as well. So with the help of femtosecond laser, the dissection, sometimes you have to do a little bit, takes some time, but it clears up nicely, and mm, you can clear up. You can see here, this is the case of a healed keratitis wherein femtosecond laser has been used. So once you remove the tissue, you can replace it with a donor lenticule. If there's any irregularity, you can smoothen it with the help of a diamond burr as well, and that will work. But don't do excessive use of diamond burr, otherwise it can cause haze. And then you place a donor lenticule, and that works well. The biggest advantage of femtosecond laser is the apposition, edge to edge apposition. You can see this is the case of a falc. The edge to edge apposition is perfect in this, because you have a vertical edge with a femtosecond laser, and that is the advantage of falc over salc, which is microkeratome assisted. If the opacity is deeper down, like this case, you can something beyond 200 microns, you cannot leave it sutureless. So you can do a automated lamellar keratoplasty or a manual keratoplasty. So uh, The idea is to reduce the density of the opacity, and then you can put a donor tissue. The advantage of automated keratoplasty is a good interface, and mm, that's how the quality of vision is good. Deep anterior lamellar keratoplasty is for diseases which involve up to the stroma, and as was discussed just now, it can be done by layer dissection as well as big bubble. The big bubble technique is the preferred technique, wherein you can create, this is a type 1 bubble which has been created. So as you give the brave slash, you reach that position, you inject viscoelastic, and must have been discussed in the previous presentation. So you sort of a divide and conquer technique. You remove the stromal tissue, and then you place the donor lenticule. We were just discussing about a macular dystrophy. Uh, I completely agree with what was discussed. Macular dystrophy, it depends on what is the stage and how much is the involvement of the stroma. If it is macular dystrophy, can involve from subepithelial area space to the endothelium. So if it's involving up to that extent, if it's involving up to desmase, then there's no point doing a DAL. Involving up to the desmase, it is in the stroma, you can go ahead and do a DALC. And intraoperative OCT does help, as you can see here. The moment you create a bubble, and behind, this is the bubble, and then as you give the brave slash, the desmase again goes up. Now you will inject the viscoelastic. So again, you can see the desmase is down, and then you can go on and dissect it. And so it's safe because you have a reasonable space. You can see the scissor movement, but the desmase has fallen quite back. It is quite behind. So you can go ahead and complete the procedure. Similar thing has happened in this case, as was being discussed. There was another bubble that in between the Duas layer and the desmase layer. And once you put a couple of sutures, you can just lift the donor lenticule and make a small puncture in the area where you have that bubble, and then you can go ahead and complete the procedure. So that is the end of it. Manual dissection, again, you have to do sometimes, because in cases like, say, healed hydrops of in keratoconus, you cannot do a big bubble DALC because there's risk of opening up of the posterior lamella. So in that case, you can do layer by layer dissection. But again, intraoperative OCT, microscope integrated OCT, helps you to know at what level you are working, and whether in one side of stroma you have in one area of cornea you have more stroma, and the other it is less. So you can make a uniform bed for the donor lenticule to be placed, and then you can suture it. So in conclusion, anterior lamellar keratoplasty is a very useful technique because the risk of rejection is negligible, and the only thing you have to decide is that what is the level that you have to reach. The idea is to remove the disease layer only and leave the healthy tissue in its place, so that we don't have much risk of rejection. We don't have excessive of donor tissue in it. But depending upon the involvement and depending upon the disease, we can decide and go ahead. If it's less than 200 microns, then you can leave it sutureless. If it's more than 200 microns, you have to do a sutured procedure. So thank you very much for your patient listening. Any suggestion or question, I'll be happy to answer.
Thank you, sir. Sir, I have seen you doing the diamond burr on the bed. So how you
Yes.
titrate the timing, that how much you should do, because you cannot see anything.
You
And
cannot.
if you do more, it will cause haze.
Yes,
So,
that's what I said, that if you do more, it will cause haze. So if you see that there is some surface irregularity, because in a case of a healed keratitis, even if you do a femtosecond assisted, when you do a dissection sometimes can be irregular in the area of scar. So what happens that if there is an obvious hill and trough, then you do use a diamond burr. Otherwise, we don't. And there also you have to be very careful. Just do a little bit. If you do excessive, it will cause haze.
10 seconds maybe. around 10 seconds or something?
Yeah, I mean, you just have to titrate, and it can vary with case to case. You cannot exactly tell that this time 10 seconds or 20 seconds, whatever you want, but you just have to titrate depending upon case to case. So it's very variable. You have to be very judicious. It can remove the irregularity, but if you do a little bit more, it can create haze as well.
Thank you, sir. As you showed that in that video, microscope integrated OCT is quite helpful, especially for manual dissection. What is your endpoint? Till what depth you would like to go for in such cases?
Which cases, which surgeries?
All
Salp,
these
valve?
cases where you are doing a manual DALC
Huh.
assisted by microscope MIOCT.
Yeah. See, it depends on the pathology. Like if it's a case of a keratoconus, and I'm doing a manual dialc layer by layer, and suppose it's a heel hydrops with the scar is at the edge of the pupil, you can still go ahead and do a dialc because as the cornea will flatten, it will go further in periphery. So there you leave a little bit of stroma. In a case of macular dystrophy, you would not like to leave any layer of stroma. So the last layer you can even hydrate and peel also when you are doing a manual dissection in a macular dystrophy. So it depends on the disease condition which you are tackling, and accordingly you have to reach the depth.
Any alternative to MIOCT somebody can use? If somebody doesn't have a MIOCT, is there
Well,
any?
there are various methods. You can inject air bubble, and then when you are using the blade, you can see the dark band which Melis used to use. That will help you an idea how much of the stroma is left. So that is also one rough idea by use of an intracameral bubble, air bubble.
Thank you, sir.